From MicrobeTV, this is TWiP, This Week in Parasitism, episode 276, recorded on March 13th, 2026. I'm Vincent Racaniello, and you're listening to the podcast all about parasites. Joining me today from New York, Daniel Griffin.
Hello, everyone.
I don't know, Daniel. Friday the 13th. It could be bad.
Nothing but trouble. Nothing but trouble.
Also joining us from Glasgow, Scotland, Christina Nowla.
Hello, everybody. No trouble here. Well, just a little.
Speaking of trouble, though, Daniel has trouble on his bow tie. It's Friday, right?
So what do you think it is? It's a tricky one.
It's a big one.
Trichomonas.
All right.
You know, I used to work, when I graduated from college, I worked in a pharmaceutical company that made trichomonacidal creams or ointments or something.
Okay. Gel.
And I used to culture the trichomonads and then mix them with dilutions of the stuff to see if it killed them.
Wow.
Okay.
So I would look at them under the microscope all the time.
They're really interesting because they only have one life cycle stage. They only have trophocytes.
And they have a nice flagella, which you can see.
They are pretty, yeah.
And they move around. It's cool.
Yeah, this is quite a special bow tie because I printed the fabric, and then this is completely handmade bow tie. So
really,
yes, yeah,
it's pretty impressive. Well, if you like these programs about science, we do a bunch of them besides TWiP, right? TWiV, TWIM, TWevo, etc. We'd love your support to produce them. You can go to microbe.tv/contribute and help us out. We'd love it. Okay, today is the day where we decode the case from a couple of weeks ago. So, Daniel, what did we have back then?
Yes, well, case from 274. This is a recent case. I was asked to consult on a man in his 60s. I was actually, sometimes we have the hospitals where we usually go. So I was actually over at one of the other hospitals. A colleague of mine was out for the week. And so I get called to consult on this gentleman who's been admitted. He's in his 60s. And it's all in the history, right? He tells me he's been experiencing weight loss of appetite, and fatigue. So I dive a little deeper. I start with tell me where it all started. Where were you born? So he was born in El Salvador. He came from El Salvador to the U.S. at age 19. Former 40-pack year smoker. He quit in 2007, right? So almost 20 years prior. He's got high blood pressure, elevated cholesterol, prediabetes. He's got gastroesophageal reflux disease. Now, he tells me that over the last 3 weeks prior to this admission, he lost 50 pounds, 20 plus kilograms. He has anorexia, just not interested in eating. He's exhausted. He did report one instance of postprandial non-bilious, non-bloody NB emesis. He says, I think I overate. Also reports a syncopal episode 1 week prior to admission. He relays that he got sweaty getting up from bed. He passed out. So he went to see his outpatient cardiologist, thinking maybe this is related to my heart. He was told that he was probably dehydrated, doesn't need to present to the ED. Though he does at that time have some elevated white blood cell count and a low sodium. So he ignores the cardiologist. He goes to the emergency room anyway. And when he gets to the emergency room, they do some vitals. He is febrile to 39.1 C. His heart rate's in the 70s and then gets up into the 90s. His white blood cell count is greater than 20,000. He's got a microcytic anemia, elevated platelets. His sodium is in the 120s. He's got a low albumin at 3 with a gamma gap. Alk Phos is 196. AST, ALT are a little elevated. He's got an elevated lactate. Chest X-ray is done. Head CT is done. No acute findings, but they do a scan of his belly, a CT-ANP, so a CT, CAT scan of his abdomen and pelvis with intravenous contrast, and they report gastric mass exophytic from the gastric antrum with associated lymph nodes in the adjacent mesentery and suggestion of direct extension into the left lobe of the liver, suspicious for malignancy. Gets an ultrasound of the liver, read as heterogeneous, multiseptated hypodense lesion measuring 6.3 by 6.9 by 8 centimeters, visualized within the right hepatic lobe without internal vascularity on color Doppler. Additionally, there's a 2.7 by 2.3 centimeter heterogeneous multiseptated hypodense lesion within the left hepatic lobe. We dive a little bit deeper into the history, and he reports that right before he became ill, he visited his mother in El Salvador for 3 days. And then upon returning to the U.S., had some loose stools, and that's when he began to feel ill.
So, Daniel, this gastric mass with associated lymph nodes, what does it mean? There's something in the nodes as well?
So there's a mass in the stomach, right? So it's going to be the antrum of the stomach. So it's going to be that lower part right by the liver. But then they say associated lymph nodes. And it's almost kind of a little bit of a step there by the radiologist, right? So the lymph nodes that are adjacent to this are actually a little enlarged.
Okay.
So they're basically saying like the adjacent lymph nodes appear abnormal. And so they're sort of trying to put it together.
So I think it's interesting that he went to a cardiologist because, we on TWiP, we have issues with cardiologists doing things they shouldn't.
We like to give them a hard time, don't we?
If it were me, if I passed out, I would go see a general medical doctor, an internist. Right?
That would actually make sense, and maybe they'll see you've got a white count of 20,000, a temp of 39, and maybe they'll, I mean,
it just seems to me you should do some tests if someone passes out, right? And not just say you're dehydrated. I don't know. But what do I know? I'm not a diagnostician.
I wouldn't
We're going to ask you to be. We're going to ask you and all our listeners to do that right now.
Yeah.
So we had quite a number of guesses for this episode because Dr. Hubbard's parasitology class at New Mexico State University assigned it to his students, and many of them wrote in. And he asked them 3 questions, which you'll see popping up. First, for 3 points, history. Describe the key exposure risk, geographic location, timeline that suggests a parasitic infection. 2, symptoms and signs. Why this is a parasite, not a bacterial infection. And what are these hepatic lesions and the gastric mass? 3, would you like some more information? And 4, what kind of specimen would you like? And diagnosis, what's your diagnosis? And so some of them, I cut a lot of the background out because it would take too long. But those are the 4 questions they were asked, and they get a certain amount of points, which I think is cool. Okay, so let's start with the first one. Christina, please.
Okay, Jason writes, greetings TWiP hosts. In episodes 274's case, I would list polycystic echinococcosis at the top of my differential diagnosis. The clinical signs, imaging, and geographic exposure are highly suggestive for infection with Echinococcus fogli. Open source literature on treatment options is scanned, but it stands to reason that these options might mirror those for cystic echinococcosis, that is, albendazole and praziquantel, coupled by the pair technique, which is in brackets explained as percutaneous aspiration, injection, reaspiration, or outright surgical removal. Warm regards. That's Jason from Seattle, a returning champion.
Should we comment that maybe that's not the right acronym? PAIR.
Oh yes.
So puncture, aspiration, installation, and then reaspiration. So just little bit of a nitpicking there, but I think I'm clever, like thinking about Vogelii as a particular, more specific diagnosis there. Jason, one of our returning champions.
Yeah, Daniel, you're next.
Philip writes, hello, TWiP team. A very challenging case. Thank you. I can't think of a single diagnosis that explains all of this patient's problems. What? Isn't there always one thing that explains everything? All right. As far as infections are concerned, we do have some that include this patient's symptoms like exposition or exposure, 19 plus years in Mesoamerica plus recent visit, primary location of his symptoms, upper GI tract, and timeline, symptoms for at least 3 weeks, and a TWiP caused the 2 lesions in the liver. But combining all these is rather difficult. Here's my thought process. The obvious. The 2 lesions you discovered via ultrasound could be cysts of Echinococcus granulosus, most likely CE2 cysts. These cysts still contain live parasites, could cause some problems if ruptured or if the immune system is tampered with. The patient's subacute symptoms, weight loss, vomiting, weakness, and lab findings, together with the exophytic gastric mass, cannot be fully explained by echinococcus. Here I would consider a second diagnosis, most likely malignancy, T4BN1M0.
So, what is that? Oh, he's going to explain it.
Yeah, he explains. No, it's good. He explains it in the email. But this is a staging where you start off with first characterizing the tumor, so the T, that's the T4B. So T4B would invasion through the serosa into adjacent structures. So it's not just localized. This means you have local invasion. N1, so that's referring to the lymph nodes, right? So N1, likely regional lymph node involvement. M0, right? That's going to be metastasis. So M0, as stated, though I would actually suspect M1 since no full body CT is provided. So oncologists would insist on a complete locks to socks scan. So there might be a hidden diagnosis that would distract our listeners. By the way, feel free to cut, delete, or tamper with this email freely. Malignancy could explain many findings: fever, leukocytosis, elevated lactate, gamma-gap from tumor necrosis, low sodium and platelets via paraneoplastic effects, and microcytic anemia from chronic blood loss. Some lab values appear intentionally omitted. Perhaps CRP and procalcitonin were intentionally held back. But back to possible infections: Mesoamerica plus liver plus upper GI tract. Here is why I tend to exclude following infectious causes other than E. granulosus. Amoebic liver abscess grows over months, explains fever, infection, but our suspected lesion is in the left part of the liver. I was taught that the right side is more prone. Amoeboma, I'm unsure if there is upper GI tract amoeboma. I thought it's more like a disease of the colon. Chagas, upper GI tract, El Salvador, or matches can even lead to malignancy, but mainly in esophagus, as I thought. But if there was a trypanosome-related involvement in this patient's stomach, this would not be of primary importance now. Tuberculoma. I was thrilled to learn that there are, in fact, gastric cases of tuberculoma. Nonetheless, it would be excluded in an imminent biopsy. And more important, this is TWiP. Treponema can be in the stomach, resemble malignancy, but to infiltrate the liver, I'm unsure. And more important, this is TWiP. Honorable mention: esophagostomiasis involves GI tract, can resemble cancer of some sort, but this patient has neither connection to West Africa nor is the colon in this patient involved. So here's my conclusion. After stabilizing the patient, next comes biopsy for confirmation. The bigger question is how to handle the potential echinococcus cysts if chemotherapy becomes necessary. Surgical management wouldn't be possible for oncology intervention. So would you consider starting albendazole preemptively or prefer a watch and wait approach? Thanks for this challenging workout for my cortex. And again, this email being so long, not because I want to hear my words or on your show. You can redact, cut, or retract. You could even say he thinks it's a malignancy plus E of the hound. All the best, Phil.
That's great. Okay. Samira writes, here's my clinical case guest. I'm in Dr. Hubbard's parasitology class. History: the key exposure risk. He was born in El Salvador, lived there 19 years, then went back for 3 days. They have dense forests, urban areas. Although it's unclear where the man was, he was clearly exposed to a parasite that's heavily impacting his health. Or he could have had long-term chronic history prior to infection. After he came back, he experienced loose stool and felt ill. Symptoms and signs. Patient presents very abnormal and rapid weight loss of 50 pounds in over 3 weeks, alongside anorexia, fatigue, passed out. The loose stools, after he came back, may suggest exposure to an intestinal parasite, indicating colon infection. However, it can be suspected that the man was an asymptomatic carrier for the 19 years he lived in El Salvador, and it flared up on his 3-day trip. Additionally, the man has lesions seen on imaging with a gastric mass, which is a sign of malignancy. It's possible the trophozoites invaded the intestinal wall, where they migrated to the liver and formed the abscesses that are consistent with the gastric mass. These are characteristics of amoebic infections, but it's important to rule out which species is invading. More info, well, it would be helpful to know where in El Salvador the man is from and where he traveled. Was it urban? Did he consume street food? Is there any abdominal pain? Specimen or test. Clearly, this man has a parasite living in his intestines, and considering his critical condition and possible malignancy, we need to do ova and parasite microscopy to detect the trophozoites or cysts of an entamoeba infection. For this case, we could also do an image-guided biopsy to determine liver lesions or inflamed tissue. PCR could rule out species. These could identify the parasite. Take 5. The guess, taking everything in mind, it would be safe to say the parasite is Entamoeba histolytica. Okay.
All right.
Christina.
Tatiana writes, after reading the case and listening, one key exposure would be the travel he took. The specific region he visited is known for multiple parasites through food. He may have ingested food that was cooked improperly or through other environmental contact. Since the patient was also born in El Salvador, there could have been prior exposures as well. That may not have been as severe. The loose stools and stomach issues, the sudden drastic weight loss, loss of appetite and fatigue point to a possible parasitic infection. Since the symptoms went on for weeks after the patient returned home, starting with the stomach issues, that leads me to believe there is an invasive infection of parasite that started in the intestine. This presentation suggests a parasitic infection due to the patient's combination of gastrointestinal issues, the lesions found on the liver, and the mass. So close to the stomach, the parasites could spread through the bloodstream and invade other organs. The cavities found in the liver are multiseptated and hypodense, along with the mass found, which strongly indicate inflammation and an invasion of that specific tissue. Knowing what I've learned in class and have researched, there is one parasite that can cause internal stomach issues, followed by invading the liver. I would request a stool sample from a patient to start, along with taking a liver biopsy in the areas of the lesions. I would ask what activities the patient participated in, what foods did he consume, were there any issues with obtaining clean drinking water. As with regards to tests and specimens, a PCR antigen test would give a clearer image of the issue. That would check for Entamoeba, Entamoeba histolytica in both the stool and the liver lesions biopsy. The test run would be the best because the organisms could be identified by the molecular or antigen-based tests. Based on the characteristics of the case presented, I would suggest that the parasite would be Entamoeba histolytica, which is one known for causing an invasive liver abscess. One test would truly confirm this, a PCR test that shows positive or an antigen test in the stool sample or biopsy from the liver lesions. Now, I think Tatiana was also in Dr. Hubbard's parasitology class.
Mm-hmm.
Yeah.
Daniel.
All right, I'll grab a few here. Some short ones. Angel, also in Hubbard's parasitology class. For this case, I think the parasite is the Entamoeba histolytica. Initially, I thought it was a tapeworm, but after looking at the symptoms, this was the most likely parasite. Carolina writes, hello, good afternoon. I believe the mystery parasite is the Entamoeba histolytica, leading more towards the extraintestinal amoebiasis, specifically hepatic amoebiasis, since the gastric mass was found infecting the left lobe of the liver. And then Jordan, a little more involved here, also in the class. History, key exposure risk. Let's see what he says. I'm sort of got to pull out the exposures. No interest in eating. Let's see. Geographic location, born El Salvador, recently visited mother back home. Let's see. Symptoms and signs. If the patient were fighting a bacterial infection or a fungal infection, the patient would experience a set of symptoms extremely faster than post 3 days. The fact that our patient also experienced hypodense lesions and multiseptated liver mass point us towards a parasitic invasion of some sorts. More info. Wants to know what was the patient drinking out of while visiting mom? Did they do any swimming or fishing? If so, did they catch and release or consume the fish? Was anyone he visited or within contact with had some sort of illness? As far as what tests, seeing the parasite is infecting his digestive system, a stool sample. And he goes with Entamoeba histolytica, and a PCR test would confirm this.
All right, Joshua was also in the class. Joshua believes the parasite to be Entamoeba histolytica. Emma is also in the class, believes this is Entamoeba histolytica. Meline, she says, well, what additional info, what is he doing in El Salvador? Where was he? What was the living conditions like? Has he noticed any blood or mucus in the stool? And for the specimen, a stool specimen would be great. And for diagnosis, we have Entamoeba histolytica. Okay, back to you, Christina.
Kayla writes, and Kayla is also in this parasitology class. After doing some research, I believe this patient is infected with amoebiasis caused by a protozoan parasite. This parasite is commonly picked up by humans by consuming unclean, contaminated water or food sources. This parasite also commonly infests the intestines of humans and damages the intestine wall, causing symptoms such as diarrhea and abdominal pain. These symptoms align closely with the patient's reported symptoms and could also match up with the patient's recent travel out of the country. I thought the parasite could possibly be a liver fluke, but the patient's large liver abscesses and diarrhea made me consider amoebiasis instead. This particular patient has a more severe case of amoebiasis because this parasite has spread through the bloodstream and into the liver, causing the liver abscesses that could be chronic. Another thing to consider when diagnosing this particular patient is his previous health concerns and his age, because they also may be affecting the patient's health.
Daniel.
All right, I'll grab a few here. Kylie, also in Caleb Hubbard's course, she is going with Entamoeba histolytica. Shaylee, also in the class, she is also going with Entamoeba histolytica, but we'll get some reasoning. Although the exophytic gastric mass and hepatic lesions initially suggest a malignancy, the patient's recent travel to El Salvador, as well as the abrupt onset of fever and increased white blood cell count, suggest an infectious etiology. I believe the masses are related to the amoeba, creating liver abscesses, as the hypodense nature of the liver lesions is a classic sign of E. histolytica once it breaches the intestinal wall. To confirm this, I would recommend a PCR assay of the stool or abscess aspirate, as I would suspect that an aspiration of the hepatic lesion would yield the classic anchovy paste, material characteristic of an amoebic abscess. Gabrielle writes, she's also going with Entamoeba histolytica. And she says, additionally, I don't think the gastric mass is malignant. My guess is that this is an amoeboma. And Sarah, I'm keeping my guess short since I'm submitting late. She also says E. histolytica. I always think of Hellman's first, so Echinococcus did cross my mind, but that just doesn't fit here. I'll do my best to submit a more detailed guess next time. Thanks for all you do, Sarah.
Jocelyn writes, Jocelyn's also in the class. Her diagnosis is amoebic liver abscess caused by E. histolytica. Despite the initial suspicion of malignancy due to the gastric mass and exophytic appearance on the CT, the patient's travel history, recent loose stools, and significant leukocytosis point toward an invasive parasitic infection. The mass likely represents the primary site of intestinal invasion, with the parasite subsequently traveling through the portal system to create the large necrotic lesions seen in the liver. I believe the diagnosis would be confirmed by positive PCR for E. histolytica from the stool or liver abscess aspirate or a high-titer amoebic serology. Christina.
Jolie writes, so the symptoms suggest, I think Jolie is also in Dr. Hubbard's class. So with regards to symptoms, she suggests a parasite rather than a bacterial fungal infection because of extreme weight loss, elevated white blood cells, gastric mass and hepatic lesion. The gastric mass and hepatic lesion suggests that the parasite is in the liver and is stealing nutrients by feeding on the liver and other organs. To get more information for a better diagnosis, I would ask if he experienced a fever or if he noticed any bug bites. And I would start by doing, so for specimens and testing, I would start by doing a blood smear to see if I could see any larvae. And if nothing shows up, I would do a spleen puncture as well. This approach is appropriate due to the extension of the liver and the possibility of a parasite traveling in the blood. And then the diagnosis, based on the signs and symptoms, I think this parasite is visceral leishmaniasis, and using an NAAT test from the spleen puncture to confirm the diagnosis. So essentially a PCR test. Shall I do the next one as well?
Sure.
Okay, Mia writes, good morning, TWiP team. Mia is also in Dr. Hubbard's parasitology course. Based on the patient's history and signs, traveling to El Salvador, diarrhea, weight loss, high fever, white blood cell count, gastric mass, elevated liver enzymes and lesions are indicators of a type of amoeba. Due to this, my guess is that the parasite is invasive in Amoeba histolytica because of its prevalence in attacking the gastrointestinal tract and the expression of symptoms. I suspect during the 60-year-old man's stay in Central America, he may have ingested the parasite through contaminated water or food because of a lack of bug bites. The parasite then made its way to the luminal crypts of the intestine, causing the diarrhea and gastric mass. From there, it left the intestinal wall through the bloodstream to a different organ, such as the liver. Amoeba histolytica entered through the portal vein into the right hepatic lobe, causing large lesions, and is now spreading to the left lobe. Looking at the man's medical history of smoking, hypertension, hyperlipidemia, and prediabetes, it is plausible that he has a harder time fighting off the extraintestinal parasitic infection because he is immune compromised. Please let me know if you have any further questions or require additional information. Thank you so much for your time. That's quite funny.
Yes. Let's stop the podcast and ask him.
All right. Alex writes, hello, I'm currently a student taking a parasitology course at New Mexico State. So going through, we get 3 more info. I would like to know more about the cardiologist visit. Specimen and test. I think a blood test would be a good idea. Stool microscopy would be good since the patient said they experienced loose stools. PCR test would also be nice. Diagnosis, I think this is E. histolytica, and then we get some reasoning there. Let me get Michelle and Alexander. one of our Vienna Parasitology Passion Club emails, right? So thank you for delivering this diagnostically challenging case with a patient in their 60s, presenting with fatigue, significant recent weight loss, fever, and unclear abdominal masses returning from El Salvador. We did find this case quite challenging, but we believe the symptoms could fit hepatic abscesses caused by Entamoeba histolytica. On presentation, patient seems to be septic, which may indicate a severe and potentially disseminated Entamoeba histolytica infection. Although multiple abscesses are not typical for amoebic liver abscesses, they can occur in advanced or untreated disease. We included Echinococcus granulosus or multilocularis in our differentials. However, given the timeline, this seems less likely. Echinococcus granulosus can produce hepatic cystic lesions, systemic symptoms, particularly in individuals from endemic regions. Echinococcus can also present with infiltrative hepatic masses, constitutional symptoms such as weight loss, and lab abnormalities that may resemble malignant or severe infectious processes.
Felix writes, perhaps if the cardiologist had taken a moment to obtain a subxiphoid view, he might have noticed the lesion in the left lobe and reconsidered his assessment. This presentation sounds consistent with an amoebic liver abscess caused by E. histolytica. Treatment with metronidazole followed by paromomycin should be appropriate. Given how ill the patient appears, I would not take any chances and would initiate broad-spectrum antibacterial coverage as well. Additionally, if the patient's last endoscopic evaluation was several years ago, I would still recommend further GI workup after clinical recovery to rule out an underlying malignancy. Greetings from Germany, Felix.
So I should comment on the subxiphoid view. Mm-hmm. So this would be, should the cardiologist have pulled out his echo, his ultrasound? The xiphoid is this process right at the inferior aspect of your sternum. And so if you direct the probe downward, so subxiphoid below the xiphoid, you actually can get some images of the liver, the left lobe of the liver, and you might actually be able to see some of this pathology.
So mine is bendable, is that right?
Yeah, it's cartilage.
Oh, it's not bone.
No, it's cartilage, yeah.
So I feel the ribs, they come together just above it, and then there's this little protrusion.
Yes, your xiphoid process, cartilaginous.
Nice. All right. Christina, you're next.
Casey writes, and Casey is also in Dr. Hubbard's class. So the key exposure risk in this case is recent travel to El Salvador, a region where Entamoeba histolytica is endemic. And the timeline is highly suggestive. So travel to endemic area, GI symptoms shortly after return, progression over 3 weeks to fever and systemic illness, and the development of hepatic lesion. This sequence strongly supports an intestinal parasitic infection that disseminated to the liver, which is classic for E. histolytica. In terms of signs and symptoms, this presentation favors a parasite over a typical bacterial fungal infection for several reasons. So we have a subacute progression, weeks rather than rapid septic deterioration. We have initial gastrointestinal symptoms followed by liver involvement, which is characteristic of invasive amoebiasis. Then there are the large multiseptated hepatic lesions without internal vascularity. This pattern is classic for an amoebic liver abscess. And then persistent hyponatremia and systemic inflammatory response without a clear bacterial source. The hepatic lesions indicate that the parasite invaded intestinal mucosa, entered the portal circulation, seeded the liver, formed abscesses, typically in the right lobe first, and the gastric mass is likely either inflammatory extension from the liver lesion or a separate pathology, possible malignancy discovered incidentally. However, an invasive amoebiasis, direct extension from liver access to adjacent structures, can occur. So, for more information, I would ask, did you have bloody diarrhea at any point? Any history of untreated dysentery in the past? Has stool ovan parasite testing been done? Has serologic testing for Entamoeba antibodies been performed? Has anyone aspirated the liver lesion? If so, what was the appearance? Classic amoebic abscess aspirate is anchovy paste material. Has endoscopy with biopsy of the gastric mass been performed? Because the CT described that gastric mass as suspicious for malignancy, we must also consider, does he both have gastric cancer and a parasitic abscess? And in regards to testing and specimens, the most appropriate diagnostic approach is 1. Serologic testing for Entamoeba histolytica antibodies, which is highly sensitive for invasive disease. and especially useful when stool studies are negative. 2, stool ovum parasite exam and antigen detection or PCR to detect cysts or trophozoites, and PCR can distinguish E. histolytica from non-pathogenic species. 3, if needed, ultrasound guided aspiration of the liver abscess. Gross appearance, thick brown anchovy paste. Microscopy may show trophozoites at lesion edge. And serology is often the most reliable test in hepatic disease because parasites may no longer be present in stool. Diagnosis, the parasite is Entamoeba histolytica. The single test result that would confirm the diagnosis is positive serum anti-Entamoeba histolytica antibodies or PCR detection of Entamoeba histolytica DNA from abscess fluid.
Daniel, why do you insist on using food to describe stuff?
Isn't it crazy?
I mean, you're going to ruin anchovies for me.
Right. But I should say, should this be Entamoeba histolytica, even though the textbooks always talk about the anchovy paste, the majority of the time it's actually more of a straw colored. So. Good.
And is it also not meant to be odorless, whereas anchovy paste has got quite a strong scent?
It does. And, maybe by saying straw colored, I've turned you off from straws and we can,
We're not supposed to use straws anyway.
No straws.
You're next, Daniel.
Grab a couple here. Walter writes, greetings, TWiP hosts. The weather is inclement in Melbourne, Australia, as usual. I reckon the parasite is Echinococcus species, possibly Vogeli. The bad news is the patient has a parasite, maybe more than one. The good news is that albendazole treats a surprisingly wide range of parasitic infestations, although I'm not sure what's causing the gastric mass. Angela writes, hello, Christina, Daniel, and Vincent. I'm a pediatric resident and recent listener to TWiP after hearing about it at this past year's ASTM&H conference in Toronto. I've been using it to help study for my DTMH exam, my Diploma in Tropical Medicine and Hygiene exam. I love the cases and Christina's section on the heroes. In regards to the case, the rapid weight loss in particular caught my attention. Just today, before I was listening to the podcast episode, I had been studying brucellosis. I just remember that patients with brucella can have extreme rapid weight loss. So when I heard the 50-pound weight loss in 3 weeks, my curiosity was piqued. Some other features fit with brucella, fever, diaphoresis, anemia, hepatitis. Brucellosis is usually treated with doxy for 6 weeks and then 1 week of an aminoglycoside. Other features don't quite fit. The hyponatremia, increased platelets, multiseptate, hypodense lesions in the liver. I thought about melioidosis, Burkholderia pseudomallei, which can occur in travelers, those with chronic diseases and diabetes. Melioidosis can cause cavitary lesions. It would be treated with TMP sulfa plus or minus doxy and a carbapenem. I realize that neither of the above are parasites. This is TWiP after all. So my final diagnosis is Entamoeba histolytica, which loves to cause hepatic lesions. Alcohol use is a risk factor. Treatment would be metronidazole followed by a luminal agent. He may also need surgical drainage. Anyway, patients in their 60s are a bit out of my wheelhouse as a pediatrician, but I hope I was somewhere in the ballpark with my guesses. Angie's writing to us from Hamilton, Ontario, Canada, and she's a PGY4 pediatric resident.
Trinity writes, this makes me think of the Matrix, right?
Yes.
I believe the parasite is Fasciola hepatica liver flukes based on recent travel to El Salvador, GI symptoms, and multiseptated hepatic lesions, which suggest parasitic migration through the GI tract and it's affecting the liver. Eric writes, I perused through neglected tropical diseases for some hints, and I think the patient has echinococcosis, likely multilocularis given the severity. There appears to be a possibility that this is E. granulosus, that has been present since his childhood and growing insidiously for the last 4+ decades. In that case, the acute presentation could be a rupture or perhaps a secondary non-parasitic infection. Either way, I'd get blood cultures and start the patient on broad-spectrum antibiotics for their acute sepsis, GenSurge and IG consults for what appears to be echinococcus of some sort. I'm not sure if aspiration biopsy is safe here, so likely just surgery. WHO has some classifications for staging, but I'm not sure there's enough info yet to determine if there's metastatic complications. My institution had an order for Echinococcus antibody IgG test, but I'm not sure it is in-house. Anyhow, the patient should likely start albendazole immediately, especially before poking around the liver lesions. Treatment with 400 milligrams BID will be a matter of months for granulosis as opposed to years for multilocularis. Excited to hear what's what. Christina.
Håkan writes, greetings TWiP team. I hope you're all doing well. This week's case was a neat one and made me think back to veterinary school and having to read CBCs and consider, I'm really sorry, the cat is just jumping on my keyboard and making everything go away. So I just had to throw her off. Right, where am I? She's about to come back. Right, I'm just going to start again. This week's case was a neat one and made me think back to the veterinary school and having to read CBCs and consider whether aspects of it were from the disease agent itself or were secondary, as I suspect some of the symptoms in this one were. While not red herrings, it seemed to me that the albuminia, hyponatremia, microcytic anemia and syncopal episodes are probably not the parasite directly causing pathology, so much as the rapid weight loss and 3 weeks of not receiving adequate nutrition. Though we also know S. stercoralis can present as hyponatremia through invasion of the adrenal glands, and that with liver dysfunction we can see hypoalbuminemia, among other complications. I suppose it is hard to say without additional medical tests and information, and that makes me glad to be more in the diagnostic and research side of work now. For differentials, I ran through a whole smorgasbord of options: Fasciola hepatica, Strongyloides stercoralis, Entamoeba histolytica, Gnathostoma, Binucleatum, Anisakis, Echinococcus vogeli, and my personal favourite option and research species, Angiostrongylus costaricensis. While probably too much to ask for, being able to get a biopsy or sample of the liver masses on aspiration would be incredibly helpful in distinguishing which of these options is most feasible. Additionally, knowing whether the white blood cell count was neutrophilic or eosinophilic, as would knowing the diet of this individual while in El Salvador, as some of these are incredibly specific in the kinds of hosts they are able to utilize for transmission opportunities. This probably all sounds like me hedging my bets, and I guess as a diagnostician and veterinarian who doesn't have to treat human cases, I have that benefit. And as this podcast is so often fond of doing, I'll pick the zebras, Echinococcus vogeli or Angiostrongylus costaricensis, over the horses, Strongyloides stercoralis or Entamoeba histolytica in this case. Final guess, Echinococcus vogeli. While not E. vogeli, I have attached a photo of the recent sand we fished out of a deer, cyst shown to be Echinococcus canadensis. P.S. I agree with your last podcast. You should definitely do more fish pathogens, both the zoonotic and non-zoonotic veterinary ones. The myxosporians are often under discussion, even among veterinarians and parasitologists, with the exception of Myxobolus cerebralis, Kudawa species, or Ceratonova shasta. The fact that scientists didn't even know they were cnidarians until the last decade is pretty incredible too. I actually just read about those today and they are pretty incredible. If you are bored, there are also all sorts of obscure new myxozoans being found in odd hosts, considering these parasites need to utilize bryozoans or polychaete worms for intermediate hosts. Oddity definite hosts include waterfowl, chelonians, frogs, and even some species of voles and shrews as liver and bladder parasites. Both forms of their spores are incredibly beautiful to see, and the nematocysts they carry when triggered are truly a sight to behold.
Okay. All right, let me finish this off with just the last couple. Petra writes, hello, dear TWiP team from exceptionally White Vienna, hoping for spring. We had 26 centimeters of snowfall just yesterday. Considering the modest diarrhea, the localization, weight loss, and Amoeba histolytica, Echinococcus wouldn't have that weight loss and systemic symptoms, though I'd also be concerned for a malignancy, gastric carcinoma. Fingers crossed it's only giant entamoeba abscesses. After stool PCR diagnosis, treatment would be metronidazole followed by paromomycin. Of course, careful tumor evaluation if the gastric lesion doesn't disappear with treatment. Greetings from my guests, the second Vienna Parasitology Club, Petra.
They need to get together and make one.
Yeah. So Justin writes, this is our last guess. In the case of the patient presenting with rapid weight loss and whose scan showed several tumors in the liver, my guess is cystic echinococcosis caused by Echinococcus granulosus sensolato. I am unsure if the exophytic gastric mass is also a sign of this infection or is an incidental finding. I'm also unsure what had caused the syncope, but did find one paper describing the symptom in patients with cardiac cysts. He certainly did not acquire this infection recently, likely many years ago. I hope treatment began quickly with PAIR, puncture, aspiration, injection, reaspiration, and surgery being strongly considered. Thanks for another highly informative episode. All the best, Justin. All right. So now we have a couple more guesses, right? Christina, let's put you on the spot. What do you think?
Well, I am feeling totally on the spot because when I first started thinking about that case, firstly, I'm so glad I'm not a doctor because I had to actually put all these abbreviations into Google to make sense and write them out so that I could even understand what they all meant. So I'm really glad I am not a clinician because I don't think I'd ever be able to remember them. So that was the first thing I wanted to say. And then the second thing is I had totally utter complete tunnel vision because also I remember I didn't really ask any questions or many questions. I kind of wish I had. So I really entirely focused on those multiseptate lesions. And when I heard that, I immediately thought of Echinococcus because, that is very descriptive of them. So I thought this is maybe an Echinococcus infection, although really, if I'm entirely honest and thinking about it while reading the cases, I think the patient is probably too sick. It could maybe be a more unusual Echinococcus species, which some of our listeners have also mentioned. I'm not really sure. I think now, having read all these other diagnoses of people who have clearly not had tunnel vision and actually paid attention to the test results and the history, I probably would maybe slowly veer towards entamoeba, but I think I just have to be honest. I haven't really thought about this well enough, and I just had tunnel vision. And before reading the diagnosis of our listeners, I just thought this must be Echinococcus, ignoring all the symptoms. And now I'm not so sure. So not my best diagnosis, but hey, I'm not a clinician, so. And I'm glad I'm not. I would make a terrible one.
Vincent, what are you thinking?
I'm not a clinician either, but I think it's E. histolytica. The travel history is consistent with it, this multiseptated lesion in the liver, but also, this acute onset, right? Loose stools, systemic decline, fever, leukocytosis. This is all consistent with E. histolytica, more serious symptoms. So that's what I thought. And I don't know about the gastric mass. I really don't know what's going on there.
Probably got more than one thing. Actually, what really flummoxed me is that weight loss. I mean, it's unimaginable, really. I mean, that's a toddler.
Yeah, that's a child. That's
It's absolutely
50 pounds. That's a lot of.
He must have been a big guy to begin with, right?
Yeah, I mean, this was about a quarter of his weight.
Right?
He was down to about 150 pounds after losing 50. So, yeah, and I like the way, Caleb Hubbard, Dr. Hubbard laid this out, sort of things to be thinking about, because I think there's a lot to sort of learn here, right? I get called by this, and really the way it was framed before I got a little more history was guy in his 60s, he's lost 50 pounds, he's got this gastric mass. We're going to plan and do a biopsy. We're worried about cancer. But, by the way, he did have a fever and a high white count. So, Dr. Griffin, can you take a look? And then the story changes, right? Then you get this, I was born in El Salvador. I grew up there. I was doing great. And then I visited my mom. And then 3 days later, this acute change. Right. So the story changes, and then you start to get a different differential. And I think the differential is important. One is that this 50-pound weight loss was not gradually over months. It was, I was doing great. I visited my mom, and then 3 days later, diarrhea. I'm not eating. I'm dehydrated. I have the syncopal episode. But the 3 weeks is also important, right? With the distinction. So, he's got a high white count. He's got a fever. We're thinking he's infected. A bacterial infection would be much more acute. You're not going to 3 to 4 weeks from onset. So that gets us to start thinking about parasites. And a lot of times when we think about diarrhea, some of the other things, it's once you get past 2 to 3 weeks, you say, okay, we're thinking more parasite. The other, I think it's really good that people have a differential because, we have in our differential, maybe this is amoebic. So we're thinking about that. Maybe this is echinococcus. Now, if it's echinococcus, we can't just go putting a needle into one of these areas and doing an aspiration, because if it's echinococcus, we could actually cause spillage, cause leakage. We could actually trigger an anaphylactic reaction. So it's important to be thinking about how do we move forward with a diagnosis without actually harming our patient. So in this patient, after getting this history, first thing I did was send off some additional tests. We sent off a stool test. We sent off a serology test looking for antibodies for echinococcus or entamoeba. And immediately in this relatively sick gentleman, basically with sepsis, right? So he had fever, high white count, tachycardia, started empiric antibiotics, which included IV metronidazole. Lo and behold, I come back the next day. He already tells me he feels much better. And the stool studies come back positive for the entamoeba. Now, a nice thing too, not only at this point do we have like a diagnosis that it's entamoeba, but we have a discussion with the gastroenterologist about let's see how this person does. Let's look at the size of these lesions, because if those multiseptated lesions are actually amoebic abscesses, this is a size that should respond to metronidazole alone. And it does. Within 48 hours, the guy feels great. Over the period of time, the actual areas start to shrink in size. Now the patient is feeling better. It's been about a week that he's in the hospital. Now they go ahead, do that endoscopy, do a biopsy of the gastric mass. And now we've got to be thinking of Occam and Hickam. And unfortunately, you can have more than one thing. So in addition to having the entamoeba histolytica, to which he is responding very well, he also, unfortunately, the biopsy from the gastric mass comes back positive for an adenocarcinoma, so a gastric cancer.
Could that be related to smoking, or not likely?
It might be related to the smoking, the alcohol, some kind of his past issues. But yeah, 40-pack, you're a smoker.
So in general, what are the prognoses for gastric cancers,
Well, I like the way someone sort of laid out. We looked to see if there's any sort of distant metastases, and there was not. So this was a localized gastric cancer, which I think was picked up incidentally earlier than it would have otherwise, because he got this parasitic infection. So in this case, the prognosis is a little better than it could be, because there is this local invasion. So that T4B that one of our emailers wrote about, the lymph nodes, we'll have to do some sampling of those lymph nodes to see if they're reactive because of the amoebic infection or if they're actually have some spread of cancer to them. But then fortunately the M0, there was no evidence of distant spread at this point.
So I presume they'll resect the tumor and then take out the nodes as well, right?
Exactly. Yep.
So he was probably quite lucky to have picked up those amoeba.
Yeah, to get this. Otherwise, he would have, time would have gone by. There would have been maybe weight loss over more months. And by then it would have been a metastatic cancer, less amenable to treatment.
Although we still need that SOX to LOX test, as this listener wrote.
Yeah, you do. You do the pan scan looking for any other potential spread.
I think it's interesting that when he first went, they didn't do a history, and it was only the ID doc that does the history.
It's interesting. A lot of times people sort of feel like, oh, straightforward guy in his 60s. He's the right age, smoker. He's at risk. Looks like he's got a cancer in the, so it's just really time to get that tissue diagnosis, time to get that biopsy. I think on the infectious disease podcast, Sarah Dong and I talk quite a bit about the added value of that ID doc who, will sit down and say, tell me the whole story. And a lot of times the least expensive test and maybe one of the most important tests is a good history.
Can I pick up on your stool test that you did for the ovan parasite?
Yes. Yeah,
because I obviously now we know that this patient has a amoebic liver abscess, and so I think, if I remember correctly, but I might be wrong, is actually that at the stage of the amoebic liver abscess, it's not guaranteed that we find amoeba in the stool.
Yeah,
did you concentrate the stool, or did you kind of, did you ask to look at multiple?
So we have PCR testing, which is nice,
you did a
right?
PCR test.
Because if you think about the timing, that's a great thing. So I sent off serology for an amoeba as well as the PCR. The serology was still negative, right? Because we're 3 weeks, so we're still at that threshold for positivity. And the PCR was positive. And that's the great thing about a PCR test is because often, I think some of our emailers wrote this as well, by the time you get the liver involvement, you may end up with a negative GI test, particularly if you're looking under the microscope.
So you didn't send for microscopy?
We did, but the PCR came back, and it comes back within 90 minutes, which is great.
Yeah, that's much quicker.
Cool. All right, let's give away a book. Get 25 guesses. So let me pick a number between 1 and 25. Click, and the number is 3.
Wow.
Tatiana, I think.
Yes, Tatiana with I think a pretty nice, thorough response there. One of the students in Caleb Hubbard's class.
Yes, so that's a student in the class. So Tatiana, if you want to get a book for free, you just send an email to TWiP@MicrobeTV. Put in the subject line TWiP 276 winner, and just send us your address. You could send your school address if you want, and we'll send you Parasitic Diseases 8th edition. There you go.
Cool.
Christina, do you have a hero for us?
I do, yeah, and I was really pleased to read that actually listeners do enjoy hearing about my heroes. I do spend quite a lot of time, Googling heroes of parasitology, and then I kind of add other questions to it. So I do spend quite a lot of time thinking about that. So I'm really glad people do enjoy that. So those of you that use parasitic diseases, I think you probably know that before many of the chapters, there is actually a one-page entry about a parasitologist of note. And many of those we have celebrated already on TWiP over the last few years, but not all of them. So I think what I've decided to do when I'm a bit indecisive, I think I'm going to be talking about those we have not celebrated from the book. And then I'll kind of mix it up with heroes that are maybe more contemporary or maybe even still alive and contributing to parasitology now. So, and actually also would like to include, and I have included heroes from both human and veterinary fields, but maybe also those that cross the boundaries and maybe disease ecologists or disease ecology parasitologists of sorts. And really, just because I find it really interesting how veterinary and human health and ecology are so closely connected. So I think that's kind of my rationale of choices going forward. But today I have actually chosen Bailey Ashford, who's the very first hero in parasitic diseases. And he lived in the latter parts of the 19th century and the first kind of third or so of the 20th century. He does actually have a medal, an award named after him. So an ASTMH award, the Bailey K. Ashford Medal, which is afforded each year for distinguished work in tropical medicine. And this kind of honours work in early to mid-career, so relatively young parasitologists or specialists in tropical medicine, and it is awarded every year. So if you do go to the ASTMH, you could maybe go and listen to that specific award lecture one year. Anyway, Bailey K. Ashford, he was born in 1873 in Washington, D.C., and I do like to talk about our hero's childhood a little bit, but I couldn't really find anything. I always think that makes them human. You know, if you read about their childhood adventures and maybe also find out why they wanted to be scientists, etc. But there's very little information other than his father died when he was very young, 10 years old. And I think, so we kind of start with his studies, and I think he was influenced maybe by his late father, who was the dean of the Georgetown School of Medicine. And this is actually where Bailey studied and graduated from in 1896. And then almost immediately he entered the US Army as a medical officer. And eventually over the years, he became a colonel. But, you know, that only came later on, but I think I'll just refer to him as Colonel Ashford. So he participated in the Spanish-American War in 1898. And this is not a war I was familiar with, but you, if you're an American listener, you may be familiar with. I looked it up. But I suppose this is a parasitology podcast and not a history podcast. I'll just give you the key points because I think it is somewhat important to our hero. So this is the war that essentially ended Spanish colonial rule in the Americas, and it resulted in the US acquisition of territories in the Western Pacific and Latin America, and that included Puerto Rico and Guam, for example. So Colonel Ashford, he was posted in Puerto Rico as part of the expeditionary troops of General Miles. And after the war, or at the end of the war, he was actually ordered to remain in Puerto Rico. And I maybe should mention that at this time he wasn't a colonel yet. I just like that word because it's written so differently from how it is pronounced. Anyway, I think his studies and experiences in tropical medicine, they were really quite useful in Puerto Rico. So he was posted on the west coast of Puerto Rico, and it was there where he was appointed to be in command of a general hospital. And, you know, there he was taking care of patients, and he did noted that the people were, and I'm going to quote him here, of a pale, dropsical and unhealthy-looking class, evidently suffering from a lack of meat, although there must be something else yet not understood. I don't know, I just find that description, it jars a little bit with me. I think, Daniel, you as a clinician probably wouldn't really describe your patients that way, but I suppose in the context of the time, that was maybe normal. So he did actually examine, so he had loads of patients and really quite ill patients, and he was a really thorough doctor. despite maybe his somewhat inappropriate word choices for describing them. So he examined patient blood, and actually he noticed in all of these patients that they had a really big increase in eosinophils, and that was up to 40% in some of the patients. And probably for you as regular listeners, you will be immediately thinking of a parasitic infection. And he also remembered that eosinophilia was common in some helminth infection. And so he went on to order to examine fecal samples of his patients. And he did find ova that he describes as containing 4 fluffy grey balls inside. And I think that's actually a pretty apt description of the eggs, as if you go and have a look at the egg later on, once you know what it was. So he was really unfortunate because he didn't have parasitic diseases. So he had to use another textbook, which I also own, Manson's Tropical Diseases, which is also a really excellent book, although it's maybe somewhat wordy. So if your time is limited, it's probably best not to get lost in it. Anyway, in that book, he was browsing and he found an egg that looked quite similar, and that was labelled Ankylostoma duodenale. And in the context of that book, this egg or these eggs were found in anemic men that were digging the St. Gotthard's tunnel in Switzerland, which is where I was raised. And actually, I do have some interesting stories really about that tunneling work that would be making a really good story in parasitology, but I'll look that up another time, because those tunnels were deep and toilets were rare. And yes, I suppose you can guess what happened to those tunnelers. Anyway, he sent a telegram to the chief surgeon of San Juan to announce his discovery. And the text of that telegram, bizarrely, is now actually engraved on a bust of himself, which you can find in a library on the medical science campus at the University of Puerto Rico. And this is what it says. Ponce, November 24, 1899. Chief Surgeon San Juan, have this day proven the cause of many pernicious progressive anemias of this island to be due to Ankylostoma duodenale, Ashford. So, he was very certain of himself, so probably not the most modest man. I don't actually know. It was probably not him who had the bust made and the telegram engraved, but it's a funny thing to do, isn't it? Daniel, what would you have on your bust later on? Occams, Hickams.
I am, and my kids can tell you I'm compiling a list of quotations to have on there. One is that the guacamole is extra, so yeah, and I will.
Good.
Coincidentally, actually, it turned out later that this hookworm was not Ankylostoma duodenale, but Necator americanus, which is the North American hookworm. But I suppose I can forgive him that because we can't really differentiate those hookworm eggs under a microscope at all. So he was a really dedicated clinician, and he investigated what we now know as hookworm anemia very carefully and very thoroughly. And I think what is important to note is that the symptoms of anemia back then, and that's maybe where we come back to his initial description, it was often described as laziness and indolence. But Ashford actually recognized this as a disease which was caused by hookworm. So he did understand that these patients were not just lazy. And actually this anemia was a leading cause of death in Puerto Rico, and it was responsible for about 12,000 deaths a year, according to some sources. And between 1903 and 1904, he led a treatment and education campaign that reached about a third of the island's population. And his work reduced the death from this hookworm anemia by 90%, which I think is really remarkable. And I think for this alone, Ashford is worth a hero a worthy hero of parasitology. But he did actually a lot more during his relatively short life. So, for example, he founded the School of Tropical Medicine in Puerto Rico. He also served in the First World War in France, so not just in the Spanish-American War. He did retire from active duty in 1928 and then went on to become faculty at the School of Tropical Medicine, which he founded. And I think it's probably also fair to say that his discoveries ultimately also led to the control of hookworm disease in the southern United States. So he received some honors, for example, an honorary degree of Doctor of Science by Georgetown University. He was also nominated, but wasn't awarded, for the Nobel Prize in Physiology and Medicine in 1915. And in 1924, he was also awarded a Distinguished Service Medal for his World War I service. So, he was a decorated man and I think a good hero of parasitology. He died quite young in 1934 in his home in San Juan. So he remained in Puerto Rico for the remainder of his life. So yeah, that's today's hero. I've already got one chosen for the next one. So you can look forward to that.
All right. Thank you, Christina. Daniel, you have another case for us?
I do, and this is a fun one, but I will warn everyone not to Google this. I want you to solve this on your own. So don't ask Google or ChatGPT or Grok or any of those. All right. So this is a fun case. A man in his 20s from Japan, living in Japan, presents with fatigue and rash. This is followed by fever and myalgia, right? All muscles hurt about 6 days after the onset of the fever and the rash. We got a little more history. He was with a group of 5 individuals. They were hunting, referred to a hunting trip prior to this, and reports that 3 of the 5 friends are just fine, but one other individual developed very similar symptoms to the symptoms that he has. He reports that they have been hunting the Ussuri brown bear, which is a larger and more aggressive bear than the Asian black bear. I added the more aggressive. He was not bragging. That was me. Now, they'd been successful. Actually, this is a man who's hunted before. They'd been successful, and all 5 of them then went ahead and consumed well-cooked bear meat. So he shares with the clinician that he is aware of the infectious risks from eating bear. So thus he knew it was important to make sure the meat was well-cooked. So it was well-cooked. They all ate this well-cooked bear meat, but his one other friend who got sick did something different from their fellow hunters. Each one of them ate a bear eyeball raw. Apparently, this tradition of eating raw bear eyeballs is felt to confer upon the person who consumes them the great vision of these animals. And so my colleague who actually saw these individuals, her English is not great, so I was hoping she would come on or they would come on and share this case, but we'll be giving the unveil in a few weeks here.
So I've made a bit of a fool myself by not asking enough questions. I think I'm going to maybe ask a few questions today. Okay. I may not have all the answers, but I'm happy to answer. So why on earth did they not? Why did that eye have to be raw?
So the interesting thought is that this isn't the first bear eyeball that this gentleman has eaten, and it's tradition to eat the bear eyeballs. And through time, there's never really been a reported problem with the bear eyeballs. And in his impression, the consumer of the eyeballs impression is that the eyeballs are a safe thing, but the meat is what you have to worry about. You have to cook that. So
okay. Okay. Well,
in America, United States, there's actually this tradition when you shoot your first deer, you actually take a bite of the raw heart.
Oh, yeah, that's not for me, I think.
The hunting or the biting of the raw heart?
I think all of it, really, and the raw eyeballs. I just can't even imagine popping that in my mouth.
Can you imagine, Christina, you bite down and it cracks and all the fluid comes out?
No, it's just not bear thinking. It's going to give me nightmares, Vincent.
It's horrible. But I don't even like the idea of shooting bears.
Yeah.
They're such magnificent animals, right?
I think if I had to eat it at gunpoint, I would probably just swallow it whole. Anyway.
It's pretty big. It's pretty big, Christina.
Okay, maybe not.
Pretty big, yeah. It's actually true. Bears have big eyes, right?
Okay, well, I hadn't thought that through.
You couldn't swallow a ping pong ball, probably. No. So the bear is at least a ping pong ball.
Okay, right.
You probably need to bite. You probably need to, there's some chewing involved here, I would think.
Oh, okay. I'm just not going to go hunting. Did they eat other types of food as well that were maybe not so well cooked?
Yeah. So one of the things about Japan, right, is Japan is a pretty developed country. Now, there is a lot of concentration in the cities. So the hunting is not what you might imagine in some countries like the U.S. where people are like off, remote, heading up with their ATV, their four-wheel drive motorized vehicles, camping far afield. You're not that far from civilization. But no, there's no report of any other concerning or suspicious ingestions other than those raw bear eyeballs. Okay, and they had access to toilets. Toilets, clean water. Yeah.
Okay, that's it for TWiP 276. You can find show notes at microbe.tv/TWiP. You can send in your guesses for this latest eyeball case to TWiP at microbe.tv. And if you enjoy these programs, we'd love your support. Microbe.tv/contribute. Daniel Griffin is at Columbia University Irving Medical Center, parasiteswithoutborders.com. Thank you, Daniel.
Oh, thank you. And everyone, be safe.
Christina Nowla is at Glasgow University. Thank you, Christina.
Oh, thank you. Had a really good time, apart from now going away with the thought of dreaming of bear eyeballs.
Yeah, think of something else. I'm Vincent Racaniello. You can find me at microbe.tv. I'd like to thank the American Society for Microbiology for their support of TWiP and Ronald Jenkins for the music. You've been listening to This Week in Parasitism. Thanks for joining us. We'll be back soon.
Another TWiP is parasitic.